Welcome to the deep dive. Imagine the sheer triumph of major upper extremity replantation, bringing a limb back from a truly devastating injury, maybe at the wrist or even higher. It's just a monumental achievement.
Absolutely, a real testament to surgical skill and innovation.
But here's the thing, that initial surgery, as incredible as it is, that's really just step one, isn't it?
That's exactly right. What truly comes after that successful replantation? That's the critical part we often maybe don't focus on enough.
We're talking about the secondary reconstructive surgery,
Yeah,
that long, often complex journey.
precisely. And that's what this deep dive is all about, mapping out that path.
Think of this as a real plastics and practice guide.
Yeah, it's tailor-made for plastic surgery residents, for attendings. Our mission here is to offer a kind of roadmap for navigating this crucial rehabilitative phase after the replant.
And we're digging into a paper that gives some really invaluable insights, right? About predicting and planning these secondary surgeries based on how the injury happened in the first place.
Exactly. It offers some fantastic pearls for clinical practice, for surgical decision-making, patient management, even, for board prep, really practical stuff.
Okay, so let's talk big picture first.
Mm.
Major upper extremity amputation, we mean wrist level and anything more proximal. The functional loss is just immense.
It really is. And, unlike lower extremity amputations where prosthetics have come such a long way and can give amazing results,
Right.
the hand and arm, they're just so intricate. That complex movement, the sensation,
Tactile sensation,
Yeah.
proprioception.
all those things that prosthetics, even the advanced ones, still struggle to fully replicate. So replantation, saving the patient's own limb, is often really the preferred way to go.
Even knowing there will be challenges down the line.
Even knowing that for the patient, it often outweighs the prosthetic option, and the initial success rates are pretty good, actually.
What kind of numbers are we talking?
Reported survival rates for the replanted limb are somewhere between, say, 77 and 93%. It depends a bit on the level and the mechanism of injury.
And I guess outcomes vary too.
Definitely. Generally, you see better functional outcomes with more distal injuries, sharp injuries, cleaner cuts, less tissue damage.
Makes sense.
But when you get to proximal injuries, high-energy crush injuries, or those awful traction avulsions, the functional results are much less predictable, often quite mixed.
And that's where the literature has maybe been a bit thin, not on saving the limb, but on the next steps.
Exactly that. There's been a significant gap regarding the specific reconstructive strategies needed to make that saved limb truly work well long-term. And that's the gap the study really helps to fill.
So let's unpack that core finding then. This is kind of the aha moment, right?
Yeah, it really is.
The study suggests that the type of secondary surgery you're likely going to need, it's actually predictable.
Yeah, remarkably so. Based on the initial injury pattern, the mechanism, the level.
Wow. So imagine you're a resident, right? You could potentially know, walking into that initial replant surgery, roughly what the next couple of years might look like for that patient's reconstruction.
That's the implication. It's not just about managing expectations, although that's huge. It actually helps you plan, prepare, counsel the patient right from day one. It could change how we approach it.
Okay, tell us about the study itself.
Sure. It was a retrospective review, looked back at 45 major upper extremity replantations over a decade at one institution, and they had an impressive 89% survival rate for the replants.
89%, that's great.
It is. But here's a really key insight for practice. Even in those successful replantations, the patients needed an average of 3 secondary surgical procedures each.
3. Wow. And I see the range was 0 to 7.
Exactly, 0 to 7. So it underscores that this isn't usually a one-and-done surgery. It's often a marathon.
And what were the most common secondary procedures overall?
The big ones were soft tissue coverage, tenolysis that's releasing stuck tendons, free-functioning muscle transfers, and tendon transfers. Understanding these common needs across the board is really key.
Okay, so let's follow that journey then, piece by piece. Where should we start? Distal?
Yeah, let's start distally. Wrist and distal forearm. Often seen as the better scenario, but still a massive challenge.
Right, you said they generally have better functional results.
Yeah.
Why is that again?
Well, usually the zone of injury is more limited. You're mainly dealing with disrupted tendons, maybe bone, but less widespread muscle damage.
Less ischemic muscle burden.
Exactly. That's crucial. And really importantly, the nerves just don't have as far to grow back to reinnervate the muscles. Shorter distance equals better chance of recovery.
Okay.
Now, here's something fascinating for acute management, a real clinical pearl, especially if you're a resident on call.
Yeah.
For these distal replants, the authors actually favor repairing the nerves before the vessels.
Nerves before vessels. That seems counterintuitive. Don't you need blood flow first?
You'd think so, right? But the rationale is pretty clever. It lets you do an incredibly accurate, grouped fascicular repair of the nerve ends in a totally bloodless field.
Ah, I see. So you get a cleaner, more precise nerve connection right at the start.
Precisely. Optimizes nerve coaptation. It's a pearl worth remembering for sure.
But okay, even with those potentially better outcomes and good initial repair, patients still face hurdles, right?
Yeah.
I imagine stiffness is a big one.
Oh, absolutely. Hand and wrist stiffness can be a real battle post-op. That's something residents will definitely see a lot in clinic.
So that leads into the secondary surgeries needed.
It does. And that brings us to the most common secondary procedure for this distal level, tenolysis, releasing those stuck tendons.
How common was that?
In this study group, 14 patients needed it. It was actually the most common secondary surgery overall for these distal amputations.
And the reasons are that stiffness, maybe contractures.
Yeah, common hand and wrist stiffness, intrinsic muscle contracture, sometimes limited thumb motion because the median and ulnar nerve recovery isn't, quite complete.
So the timing question comes up again. When do you actually go in and do the tenolysis? You don't want to do it too early, I guess.
Exactly. You want to give those nerves the best possible chance to recover on their own first. So generally, for residents thinking about this, contracture release and tenolysis are delayed, minimum of 6 months.
6 months minimum.
Often you're observing for up to a year, letting things plateau. You intervene when there's a clear functional deficit that's not improving, and their range of motion, active or passive, has hit a wall.
Okay, so tenolysis helps with movement. But what if that's not enough? Or there are other deficits still hanging around?
Then you start looking at later reconstructive options. The next most common were tendon transfers.
Using working muscles to do the job of ones that aren't.
Exactly. That was done in 7 patients in this group. And then you have arthrodesis, which is fusing a joint.
Joint fusion, which joints typically.
Usually the wrist or sometimes the thumb CMC joint. That was needed in 5 patients here. But importantly, arthrodesis is usually a later salvage procedure.
Like a last resort.
Pretty much. It's reserved for when other strategies to get a stable wrist or an opposable thumb just aren't possible, maybe because there aren't enough good tendons to transfer. It was actually the most delayed procedure in the whole study, average of 3 years after the replant.
3 years. Wow, that really highlights it's for when other options are exhausted.
It does.
But there was some really good news in this distal group too, wasn't there? Something surprising.
Yes. A little aha moment. There were 2 patients, both with sharp, clean, wrist-level amputations, who needed 0 secondary reconstructive surgeries.
0 after a major replant. That's incredible.
It is. It shows that in the absolute best-case scenario, pristine, sharp injury, perfect initial repair, maybe a bit of good luck, an exceptional outcome is possible without more surgery.
That's the gold standard we're aiming for, I guess.
Absolutely. But we have to be realistic. It's definitely the exception, not the rule.
Okay, so that's distal. Now,
Yeah.
proximal. This is where it gets, as you said, really interesting and maybe the most challenging. Proximal forearm and elbow.
Yeah, this is arguably where the biggest hurdles lie, both for the initial salvage and for the later reconstruction.
You can just picture the trauma involved. Much higher energy, typically.
Often, yes. You frequently have a much larger zone of injury. You can get direct damage to the nerve motor end plates in the muscle, injury right at the musculotendinous junction, all things that point towards predictably poorer functional recovery.
And you mentioned avulsion injuries being particularly tricky here.
Extremely tricky. In traction or avulsion injuries, the vessels and nerves often get ripped out at different levels. It makes a clean primary repair incredibly difficult, sometimes impossible.
So what's the key message for the surgical team dealing with this acutely? A resident facing this in the OR?
A really crucial pearl for the initial operative strategy here is adequate bone shortening and aggressive debridement, especially of the distal amputated part.
Bone shortening. How much are we talking?
The paper mentions accepting forearm shortening up to 6 to 8 centimeters if it helps you get a primary nerve repair or vessel anastomosis without needing grafts.
6 to 8 centimeters? That's a lot, but I guess the benefits outweigh the length loss.
They often do. It reduces the time needed for revascularization because you might avoid vein grafts. It shortens the nerve gap you need to bridge. It removes potentially contaminated bone. And it might even decrease the need for secondary soft tissue coverage later. It's a critical step for limb salvage and setting up for better long-term outcomes.
Okay, but even with good initial management, the nerve recovery picture sounds pretty bleak here compared to distal injuries.
It is, unfortunately.
So how does that change the reconstructive philosophy? If the nerves aren't coming back well, what's the main issue causing the functional problems?
Right. At this proximal forearm and elbow level, it's likely insufficient neuromuscular recovery itself, rather than just tendons getting stuck like you see more distally. The motor units might just not be viable.
Which makes standard tendon transfers difficult.
Very difficult, yes, because you need healthy, reinnervated muscle to transfer from.
So what do you do instead?
This is where free-functioning muscle transfer, FFMT, becomes the workhorse.
Bringing in a whole new muscle with his own nerve and blood supply.
Exactly. Predominantly using the gracilis muscle from the thigh. This was the most common secondary procedure in this group, 11 FFMTs in 6 patients.
And what's the goal of the FFMT here?
It's used to reconstruct major deficits, usually wrist and finger flexion and dare extension, when the patient still has significant functional limits despite good rehab, long after you'd expect any nerve recovery to have happened.
Is there a typical time frame for considering FFMT for residents planning long-term care?
Yes, there's a guideline. It's generally considered if the patient hasn't achieved at least M3 motor strength, that's movement against gravity, by about 1 year post-replantation.
1 year.
And the first FFMT is typically performed around 14 months after the initial replant. If they need a second one, say for both flexion and extension deficits,
A double transfer.
right, then the second transfer is usually staged about 6 to 12 months after the first. So you might be looking at around 22 months post-replant for that second FFMT.
Okay, that's helpful timing guidance. What about the technical side of FFMT? Any key pearls there?
A huge takeaway is that FFMT needs a healthy proximal recipient nerve to power the new muscle.
So that initial debridement and nerve management is critical again.
Absolutely critical. You have to preserve nerve length proximally whenever possible during that first surgery.
And what if there just isn't a good nerve available in the injured arm?
That's where you might need to look elsewhere. The intercostal nerves, specifically the 3rd to 5th ones, can be used as donors. That's a classic technique and definitely something to know for boards.
Intercostals. Got it. And sensory reconstruction.
Also vital. Nerve grafting is often needed, especially to restore sensation in the median nerve distribution if possible.
Okay, now let's move even further up. Upper arm replantations. This feels like the absolute highest stakes.
It really is. These often result from the highest energy mechanisms, leading to the most severe initial damage.
So massive contamination, infection risk.
Huge challenges right from the start. Extensive contamination, chronic infection is a major worry, and you often need secondary procedures just for soft tissue coverage or to manage bone non-unions.
So what's the most common secondary surgery here then?
At this level, it's soft tissue coverage. That was needed in 10 cases in this study.
And is there a preferred way to do that coverage early on?
Yes, another important clinical pearl here. When it's feasible, early soft tissue coverage with a flap is strongly favored over using just a skin graft.
Why is that? What's wrong with a skin graft initially?
A skin graft, especially over muscle, will inevitably contract and scar down. That restricts muscle movement, muscle excursion.
So you solve the coverage problem but create a motion problem.
Exactly. And then you often end up needing a later tenolysis, and you have to replace the contracted graft with a flap anyway. So doing the flap early, if possible, prevents that whole secondary cascade.
Trying to think 1 or 2 steps ahead, even in the acute phase.
That's the name of the game.
And the muscle ischemia, the nerve regeneration challenges, or are they just even worse here?
They're definitely magnified at the upper arm level, yes. It significantly worsens the expected functional recovery.
Which muscles are most affected?
The primary muscle injury often hits the biceps and triceps directly, which obviously compromises elbow motion. If the musculocutaneous nerve or the radial nerve are badly damaged, restoring good elbow flexion and extension is predictably very difficult.
But you mentioned some innovative approaches earlier, something about early transfers.
Yes, the study highlighted two fascinating cases of transhumeral, so above elbow, replantations, where they performed early pedicled functional latissimus dorsi muscle transfers.
Early meaning how early?
Really early, like 27 and 48 days after the replantation.
Wow. And that was to restore what function?
Elbow function, primarily, but also contributing to wrist extension in these cases. And the beauty of using the latissimus as a pedicled flap is...
It brings its own blood supply.
Right, and it provides that crucial soft tissue coverage at the same time.
A two-for-one solution. That's elegant.
Very elegant. It's a complex decision. Doing a functional transfer that early in an acute setting definitely has risks.
Higher technical demand, flap risks.
Sure. But the potential upside of getting function back sooner, maybe shortening the whole rehab process, is significant. It's a balance.
Okay, so that addresses elbow function. What about hand function? Because the forearm muscles themselves might be, okay, just disconnected, right?
That's a key difference at this level. Unlike the proximal forearm injuries, where the muscles themselves might be unsalvageable.
Right, needing FFMT.
In upper arm replants, the forearm muscles are often relatively preserved, just denervated. So the strategy for distal function for the hand and wrist is different.
How so?
You generally don't rely on free-functioning muscle transfers for distal function here. There was only one FFMT used for that purpose in this upper arm group.
Because the original muscles are still there.
Exactly. So the goal becomes trying to reinnervate those existing distal muscle groups.
Through nerve transfers or nerve grafts?
Precisely, trying to hook up working nerves to the denervated forearm muscles.
But it sounds incredibly complex to plan reconstruction at this level.
It is. The study acknowledges that a single specific algorithm is really difficult because the patterns of nerve injury and functional return vary so much.
So they're more about principles.
Yes, the general principles still apply. Figure out what function is present, what's missing, what donors you have available. Then you use a combination, maybe FFMT for elbow flexion if needed, pedicled transfers like the latissimus, standard tendon transfers if possible, maybe joint fusions to try and achieve useful elbow motion and a stable hand with at least basic grasp and release.
A truly customized approach for each patient.
Absolutely. And it's also sobering to note that in 2 patients in this upper arm cohort, no secondary reconstructive surgery was even offered.
Why not?
Just too limited in terms of available donor muscles and nerves. It highlights the severe limitations you can face at this most proximal level.
Okay, let's zoom out again. Looking across all these levels, distal, forearm, upper arm, what are some overarching pearls for managing these patients through this long journey? Any key takeaways for residents and attendings?
Well, first, a crucial point about failure, unfortunately. We mentioned the 89% survival rate, but that means 11% failed.
5 out of the 45 replants failed, right?
Yeah.
And ended in amputation.
Correct. And the really stark finding was that in all 5 of those failed cases, deep infection was thought to be the primary cause.
All 5 due to infection. What were the injury types?
Crush injury in 4 and avulsion in 1. High-energy contaminated injuries.
And how quickly did failure happen?
Swiftly. The average time from the replantation surgery to the eventual amputation was only 11 days.
11 days. That really underscores the need for extreme vigilance for infection, especially in those crush and avulsion cases.
Absolutely. Intense monitoring, low threshold for intervention if you suspect anything. It's critical in those first couple of weeks.
Okay, what about the timing of the successful secondary surgeries? You gave some specifics for FFMT, but overall?
Overall, the average time from the initial injury to the final reconstructive surgery was about 17 months. But the range was huge from basically 0 days, meaning maybe early coverage, up to 6 years later.
6 years.
Yes, it can be a very long road, but there's a general sequence you often see.
Like what?
Soft tissue coverage procedures tend to happen earliest, mean of about 24 days. Then come bone and nerve reconstructions, things like bone grafts or nerve grafts average around 7 to 8 months.
Okay.
Then the procedures focus more on function, like tenolysis, tendon transfers, contracture releases. Those most commonly happen between the first and second year, average 18 to 21 months.
And then arthrodesis, the joint fusions, are last.
Typically, yes. As we said, average around 3 years. Having that general timeline in mind is really helpful for planning and for counseling patients about what to expect.
Definitely. And how is the decision actually made to proceed with the secondary surgery? What are the criteria?
It's really a joint decision between the surgeon and the patient. It happens once the patient has kind of plateaued with their therapy. They're not making further gains, but they still have functional limitations that bother them.
And there's a specific functional benchmark.
Yes, for procedures aimed at boosting function like nerve grafts, tendon transfers, FFMTs, They're generally considered if the patient fails to achieve better than M3 motor strength.
M3, movement against gravity.
Right. If they can't actively move the part against gravity after sufficient time and therapy, then you start seriously considering these functional reconstructions.
Okay, so it's this long, multi-stage process, potentially years of surgery and rehab. But what about the bottom line? Patient satisfaction. Was anyone sorry they went through it all?
That's maybe the most encouraging finding. In this group of 40 patients whose replants survived, with follow-up going out to 7.5 years,
Yeah.
no patient was unhappy enough with how their limb worked to ask for a secondary amputation later on.
None of them.
None. Which strongly suggests that despite the long journey and imperfect outcomes, they were overall satisfied with having salvaged their limb.
That's a really powerful message. It validates the immense effort involved.
It absolutely does. It's something important to convey to patients when they're facing this daunting prospect.
Now, we should briefly touch on limitations, as with any study.
Of course, it's a retrospective review from a single center, so no statistical analysis comparing groups, no super detailed functional outcome scores beyond the types and timing of surgeries, and they didn't specifically look at things like patient comorbidities or what the patient's job or demands were.
But still valuable data.
Immensely valuable,
Yeah.
especially because major replantation surgery is, realistically, being done less frequently now and by fewer surgeons with deep experience. So these kinds of detailed case series from high-volume centers are absolutely essential. They provide crucial data to inform clinical decisions for those of us actually doing this work for plastics in practice.
So let's wrap this up. What's the big takeaway here? What does this all mean for the surgeon managing these complex cases?
I think the core message is that while replantation itself is a monumental achievement, that subsequent reconstructive journey, it's not just a random series of events. It's not a shot in the dark.
It's predictable.
To a remarkable degree, yes. The type of secondary surgery needed seems to follow predictable patterns based on that initial injury, the level, the mechanism.
And that's vital intelligence for any plastic surgery resident or attending. It lets you shift from being purely reactive to being much more proactive in planning care.
Absolutely. This kind of framework helps you prepare patients better for what's likely ahead, this long, complex journey. But it also lets you, the surgeon, proactively plan for the specific interventions they'll probably need down the line.
Which leads to a final thought, maybe a question for our listeners to ponder.
Exactly. If we know this much based on the initial injury pattern, it begs the question, how much more could we refine our initial assessment, right after the replant or even during it?
To get even better at predicting the future needs.
Yeah. Could we anticipate, maybe even mitigate, the need for some secondary reconstructions by optimizing that very first intervention even more? Are there subtle cues, maybe in nerve recovery tests, early imaging, tissue quality assessments in the immediate post-replant period that could give us even more predictive power?
Sharpening our ability to forecast and plan for the best possible long-term function right from day one.
That's the goal. Something definitely worth thinking about as you approach your next complex upper extremity reconstruction case.